Hello, everyone, and welcome to the Academy for Eating Disorders webinar entitled Cognitive Behavioral Therapy for Avoidant Restrictive Food Intake Disorder with Drs. Jennifer Thomas and Cameron Eddy. My name is Marcia Heron, and I'm your moderator today. Also with us is Ronald Fan, AED's membership manager and webinar magic maker. If we have problems, he'll help us out. If you have any questions or concerns about this webinar, please feel free to reach out to Don Gannon at AED headquarters via email at dgannon@aedweb.org. Now, just a couple of housekeeping items before we get started. All the participants are muted with the exception of the speakers and myself. The webinar is scheduled for 60 minutes and it is being recorded. It will be posted on the AED website shortly thereafter for AED members to download at their convenience, 24 hours a day, 7 days a week. There are other webinars there. Check them out. They're excellent. In just a few minutes, Dr. Thomas and Dr. Eddy will begin their presentation, after which they will answer questions from the audience. Here's how that's going to work. You can submit your questions to the speakers during the presentation using the Q&A text box at the bottom middle of your screen. And I will read the questions to the speakers when the question portion at the end of the webinar begins. Another housekeeping matter. Let's test volume. Dr. Thomas and Dr. Eddy, could you just say hello? And then participants, can you let me know if you can hear them clearly by sending a message on the Q&A text box that I just mentioned. And then we'll get started.
Hi,
Dr. Thomas, yeah?
Hi, it's Cameron Eddy here as well.
Oh, yep, people are hearing you and me, I assume. So it looks like we are good to go. The volume is okay. Good, good. Okay, let me start by introducing our speakers. Jennifer Thomas, PhD, is co-director of the Eating Disorder Clinical and Research Program at Massachusetts General Hospital. I just have to pause here and say, Jennifer did her undergraduate at Dartmouth College, and I'm at Dartmouth Med School. We're very proud of her, to say the least. She is Associate Professor of Psychology in the Department of Psychiatry at Harvard Medical School. Her scientific research focuses on neurobiology and the treatment of feeding and eating disorders. She has been funded by the National Institute of Mental Health and private foundations. She is currently a major PI on an NIMH-funded study on, no surprise, the neurobiology of avoidant restrictive food intake disorder. Henceforth, we are going to call ARFID. Dr. Thomas's books, Almost Anorexic, is my or my loved one's relationship with food a problem. It's an excellent book for patients, by the way, with atypical anorexia, and Cognitive Behavior Therapy for Avoidant Restrictive Food Intake Disorders, Children, Adolescents, and Adults. Also an excellent book for practitioners. Very helpful to me in my work. She has over 120 peer-reviewed articles and book chapters. Along with her colleague, Dr. Cameron Eddy, she has developed the new cognitive behavioral treatment for ARFID that will be described in this webinar. Dr. Thomas is also Secretary of the Academy for Eating Disorders and Associate Editor of the International Journal of Eating Disorders. Cameron Eddy, PhD, is co-director of the Eating Disorder Clinical and Research Program at Mass General Hospital. and also Associate Professor of Psychology at the Department of Psychiatry at Harvard Medical School. Her research and clinical work focuses on low-weight eating disorders, particularly anorexia nervosa and ARFID in children, adolescents, and adults. She is currently a major PI on 2 National Institutes of Mental Health funded studies investigating the neurobiology and outcome of low-weight eating disorders, and she has published over 120 peer-reviewed articles and book chapters on eating disorders. And along with Dr. Thomas, she has developed the new cognitive behavioral treatment for ARFID that will be described and presented in this webinar. Thank you, Dr. Thomas and Dr. Eddy. Please start.
Thank you so much for that kind introduction, Marcia. This is Jenny speaking. Cameron and I are delighted to be here and to see such a great turnout among our friends and colleagues, and are honored to have been invited by the Academy for Eating Disorders to present our webinar entitled Cognitive Behavioral Therapy, CBT, for Avoidant Restrictive Food Intake Disorder, ARFID. Before we get started, I just wanted to indicate a few disclosures that we have. So you can see that there are a few books that I've written and received royalties on, and Cameron has the same as well. All right, so given that you're signing on to a webinar that's about ARFID, we're imagining that you're probably pretty familiar with the diagnostic criteria, but just so that all of us are starting with the same background information, we just wanted to mention that ARFID is really a reformulation of a diagnosis in DSM-4 called Feeding Disorder of Infancy and Early Childhood, and was really put to the forefront with the publication of DSM-5 in 2013. ARFID is characterized by food avoidance or restriction that leads to failure to meet nutritional needs, and it has to be causing some problems for the person, whether that be significant weight loss or inability to maintain weight, whether it's nutritional deficiency like low vitamin C or scurvy. It might be dependence on tube feeding or oral supplements, so having to take vitamins and minerals either through pills or through special drinks, or causing psychosocial impairment. Many individuals with ARFID have difficulty working or attending school or social events because of their restriction and avoidance. The problem can't be due to lack of available food or just due to cultural practice. It can't be due to fear of weight gain or body image disturbance like we see in anorexia nervosa or bulimia nervosa, and it can't be accounted for by another medical or psychiatric condition. Now, one of the things that we notice in our clinical work, and imagine that many of you have as well, is that there are certainly a lot of similarities between ARFID and anorexia nervosa, but the primary difference is that individuals with anorexia nervosa have higher levels of cognitive restraint. So in other words, they will indicate that they are trying to diet, trying to eat food that's low in calories or energy density, whereas individuals with ARFID don't say yes to those kind of items on cognitive restraint, and instead they're actually fairly similar to folks with anorexia nervosa on measures of actual food restriction. So in other words, they are limiting their intake, perhaps eating a low volume or a low variety of foods, but it's not due to reasons having to do with shape and weight or trying to diet. So then you might be wondering, well, then why are these folks restricting their intake? Well, DSM-5 posits that there are 3 different potential rationales for food restriction and avoidance. One of them is food selectivity due to sensory sensitivity. So these are folks that, they only eat a very small variety of food because they're worried that new foods will taste disgusting or have a strange texture, or maybe be an odd temperature and just not something that they prefer. They tend to eat the same foods over and over. There are individuals who have a lack of interest in food or eating. So they tend to be those that say that eating is a chore, that they have difficulty being interested in eating food and they just don't feel hungry. And then lastly, there are folks who have a fear of aversive consequences. So typically they're afraid of things like choking or vomiting or having an allergic reaction. One of the things that we started to wonder about in our work is whether these prototypes are categorical or dimensional, which does have implications for treatment. So you could think of these ARFID profiles as subtypes, so a sensory type or a low appetite type or a phobia type. But what we've come to start thinking about here at Mass General is that we actually think that these presentations represent dimensions. So in other words, that some individuals may present with multiple rationales for food restriction and avoidance. So somebody might have a choking phobia that's overlaid on top of low appetite and sensory sensitivity. And we started to take a look at whether these dimensions might be underlied by specific neurobiology. And one of the ways that we've begun to investigate that is that we've worked with our colleague Rachel Bryant-Waugh in the UK to develop a new structured interview called the PICA, ARFID, and Rumination Disorder Interview, or PARTI, which is a 45-minute investigator-based interview that can allow you to confer diagnoses of ARFID and determine the severity along these different dimensions. It has shown evidence of good reliability and validity and is freely available online. You'll see a link to how you can access the instrument at the end of our slide deck. And one thing I wanted to mention about the PARTI is that it does look like we're developing some evidence that these ARFID presentations may be dimensional. So on this slide, what you see on the y-axis is the severity on each dimension on the PARTI subscales representing each of the ARFID profiles. And on the x-axis, each number represents one participant or individual in our studies. And as you can see, there are some folks who are high in multiple dimensions and some who are only high on one. But the idea here is that any treatment that we develop, we wanted to make sure it was flexible and could address this heterogeneity within ARFID. And so lastly, before I turn it over to Dr. Eddy, I just wanted to mention that, again, we are curious about whether there might be distinctive neurobiology underlying these different dimensions. And so, for example, folks who say that they're not hungry and eating is a chore, perhaps they have low levels of hedonic eating, or there's something going on with their endocrine hormones that makes them less hungry. Folks who have that phobic anxiety, maybe they're having higher amygdala reaction or cortisol reaction in these situations related to eating and food. And folks with sensory sensitivity, maybe food is tasting really intense to them, and that makes it difficult for them to take on board new foods. And so please watch this space because we hope to be publishing some of these data very soon.
So now this is Cameron. I'm pleased to be here as well. So now I have an opportunity to tell you guys a little bit about for whom is CBT-AR appropriate. So this is an outpatient treatment that Jenny and I developed. We think of it as appropriate for kids, adolescents, and adults who are 10 years old and older. These are folks who have a diagnosis of ARFID. They're folks who are able to cognitively engage in treatment. So typically that's folks who are 10 and older. It's true that there are times where we will use this treatment for slightly younger kids, and there are some groups who are working to adapt it. But in our experience, it's best for kids who are 10 and older. And by older, we do mean all the way up to adults. So we also use this treatment for adults and older adults. In order to be a fit for outpatient CBT-AR, people need to be eating by mouth. That means that they're able to at least consume drinks and foods by mouth and don't require tube feeding. In our experience, folks who require tube feeding really do require a different kind of treatment. Folks need to be monitored by a physician. We know that ARFID can have some serious medical consequences, and so to be safe, we ask that patients are monitored by a physician throughout treatment. Treatment proceeds through 4 stages. In the first stage of treatment, which is psychoeducation and early change, this piece is usually 2 to 4 sessions. It can be up to 4 sessions for individuals who are low weight and require an additional 2 sessions for refeeding. Stage 2 is the briefest, and this is treatment planning. Really what we're doing in stage 2 is setting the stage for stage 3, making a plan for what we're going to be doing in stage 3, which we think of as the heart of the treatment. In stage 3, we're addressing the maintaining mechanisms for each ARFID domain that's relevant for the patient. Usually this stage can last between 14 and 22 sessions. It's variable based on how many maintaining mechanisms we're addressing, but also based on the severity of the presentations. And then finally, in stage 4, we're doing relapse prevention and ending well. The treatment CBT-AR can be delivered in one of 2 formats. First is family-supported treatment, and this we'll use for all individuals who are 15 years and younger. We'll also use it for young adult patients who may be older than 15 when they live at home and they have significant weight to gain. As has been our experience, for folks who have weight to gain, it's much more challenging for them to do that in individual treatment, and so for that reason, we do rely on parents and caregivers as well. Individual CBT-AR is appropriate for late adolescents and adult patients who don't have significant weight to gain. And then finally, although the session attendees do differ, the interventions are really the same across the age span. A typical outline of a given session for CBT-AR is going to look familiar to anybody who does CBT. First, what we'll do is verbally set the session agenda with the patient. Second, we'll take the patient's weight. We do this together and share the weight with the patient openly. Third, we'll review the homework from last session. And then fourth, we'll implement whatever intervention is related to the current treatment stage. We'll talk a little bit more about this as we go through the treatment. Fifth, we'll review any agenda items that the patient may have brought in, him or herself, or the family members may have brought in, and then we'll plan the homework sessions for the coming week. Okay. Stage 1 of CBT-AR really focuses on psychoeducation and early change. We find that many folks coming in have researched ARFID. They've been looking for a lot of information about ARFID, but at the same time, they're really lacking in general information about ARFID. So we spend a lot of time talking specifically about some of the neurobiological work on ARFID, some of the just basic kind of understanding of avoidant and restrictive eating, and also highlighting for them the 3 different presentations so that they can have a sense about which one may be the best fit for them and which portions may resonate most for them. We introduce self or parent monitoring from the beginning of treatment. Of course, in the individual format, we'll do self-monitoring, and in the family-based format, we'll suggest parent monitoring. And this is really to encourage the parents to take charge of the child's eating, particularly in kids who need to gain weight. We encourage regular eating in stage 1. And for regular eating, what we're talking about is regular eating in the sense of timing. So we're asking them to eat 3 meals a day and 2 to 3 snacks. But really what we're asking is that they rely on heavily preferred foods at the beginning of treatment. We are asking them to make small changes, and I'll tell you about that in a moment. In the second session of stage 1, we're doing a personalized formulation, and I'll walk through those in just a minute. For the patients who are underweight, we're asking them to make early change from session 1. And for them, because we want to focus on weight restoration from the beginning or weight gain, we're asking them to begin to weight restore by increasing the volume of preferred foods. Typically, this means eating 500 extra calories of preferred foods. Similar to what we will do in family-based treatment for eating disorders, for anorexia, we will also conduct an in-session therapeutic meal where we provide coaching to the parents and to the family around helping to refeed their kid. We also will do an in-session therapeutic meal for low-weight patients, adult patients who are in the individual format. And in that way, we'll provide coaching to the patient, him or herself. If the patient is not underweight, we're also advocating for early change. And instead of increasing the volume, we're asking them to make small changes in presentation of preferred foods, really to begin to make changes in variety. So either they're making changes in the way that the preferred foods are looking or when they're served, or we're asking them to reintroduce recently dropped foods. This is an example of some of the psychoeducation that we'll do in stage 1. You can see we'll walk through what is ARFID, helping them to understand that there are different presentations of ARFID. They may have 1 or 2 or all 3 of these presentations, again, because they're dimensional rather than subtypes, and that ARFID is a psychiatric disorder.
And we will have a link so that you can download a copy of the workbook for free at the end of the slides.
Thanks for mentioning that. So I should say that as well. From the very beginning of treatment, we give the patient a workbook, and we give them this free workbook that Jenny just mentioned. It's downloadable for you and also for them. We ask them to take home the workbook and to bring it with them to every single session because it's something that we continue to come back to. This is an example of a big picture formulation of ARFID. And this is sort of a template that you can use, but what we ask and what we do is we work through this individually with the patient and family. So the way that we understand ARFID is that typically what is bringing folks in is the food restriction, which we see as kind of the center point. The food restriction, which can be in volume and or variety, that leads to nutritional compromise. For some people, that will be low weight. For others, it might be things like nutritional deficiencies. And for many folks, it will also lead to limited opportunities for exposure. So for many folks, they're presenting because they are at a low weight, the nutritional compromise, or they're presenting to us because their pattern of food restriction is really interfering with their ability to participate in life. They're not able to eat with friends, they're not able to go to work activities or events. And at this point, their families or friends have stopped expecting them to eat new things. So they also have limited opportunities for exposure because they're no longer around people eating a wide variety of foods. You can see in the model, what we have are arrows going from nutritional compromise and limited opportunities for exposure back up to food restriction because those are maintaining. What we think about is that there are likely biological predispositions that set people up for ARFID, and for some, they may have a food-related trauma, particularly those who experience the fear of aversive consequences. These biological predispositions or situational traumas can lead to negative feelings and predictions about what eating will be like, and in turn that leads to food restriction. So this gives you a picture of the big picture model, and then what we'll do individually is work through the model, particularly for any given patient. We expect in CBT-AR that patients will be making big changes from day 1. Again, for the underweight patients, we're asking them to start by adding 500 calories a day, really from day 1. And in our workbook, we have examples about how the patient might do this. For the non-underweight patients, we're also asking them to make change from day 1. Examples of this could be small changes in presentation of preferred foods. It could be bringing back recently dropped foods, but it also could be things like rotating preferred meals. If they typically have the same breakfast every day or the same snacks every day, we're trying to encourage them to make some rotations there. In terms of eliminating minor safety behaviors, this is appropriate certainly for the patients with fear of aversive consequences. We're encouraging them to make some small changes there from the beginning. Again, with regular eating, we're asking them to eat 3 meals and 2 to 3 snacks. We're asking them to do the food log so that we can look at that carefully together. And again, for underweight patients, we're encouraging them to be doing 3 snacks a day. Just to briefly mention, in stage 1, the therapeutic meal, In this, it's going to look familiar for folks who have done family-based treatment because there are some real similarities. In this, we're asking them to bring in a meal that will begin to help their child get on track or help the individual to get on track. They're bringing in a meal that comprises energy-dense preferred foods with one novel presentation. As the therapist, we're advocating for the parents to make very specific recommendations to their child around eating speed, making specific requests like taking another bite of pizza, and really persisting with reasonable demands, empathizing with them in terms of how hard it is, but also being confident that they can do it, and then giving specific praise. And then we're asking them to go forward and do this outside of our sessions as well. After the patient has eaten a bit more in terms of adequate volume, the parents or the therapist are asking them or encouraging them to take one bite of a novel item. For patients who are underweight, the focus is really on increasing volume of preferred foods, which tend to be energy dense, again, in contrast to the patients with anorexia nervosa, but also then encouraging them to take one bite of a novel presentation. After 2 to 4 sessions at stage 1, we're ready to take an inventory to see if we're ready to move to stage 2. At this point, the patient and their family will have a good understanding of ARFID and what happens in CBT-AR. The patient should have a good understanding of his or her specific presentation. They should have established self-monitoring of daily food intake and really be eating at regular intervals at this point. And the patient should have been engaging in small changes, increasing volume or variety. And this is something that we ask them to do from day 1, but every day going forward. Now I'll turn it to Jenny for stage 2.
All right, so in stage 2, the two main things that we'd like to accomplish is that first we want to provide psychoeducation about the 5 basic food groups, as well as nutrition deficiencies that can occur if people are not eating what they need to eat. And then we want to work with patients and their families to select new foods to learn about in stage 3. And that phrasing of learning about new foods is very intentional. The treatment is not about forcing people to eat things that they don't want to eat. It's really about increasing exposure and comfort level with a wide variety of novel foods that are strategically selected in order to help folks reduce nutrition deficiencies, expand their representation across the 5 food groups that the USDA has identified on the MyPlate, and that also might reduce a psychosocial impairment. One of the first exercises that we do with patients in stage 2 is to give them a little bit of education about the MyPlate that the U.S. Department of Food and Agriculture has suggested sort of as a schematic for a healthy eating meal. And what we actually found in our research is that individuals who don't have ARFID actually tend to eat meals throughout the day that pretty much do conform to this plate. So they'll have a variety of some dairy or dairy substitute foods, some grains, some protein, some vegetables, and fruits. And so, maybe a little bit less vegetables than the USDA would suggest, but overall, they're having a variety of foods. What we found with folks with ARFID and subthreshold ARFIDs from our studies is that actually their plate tends to be a bit more lopsided. You can see they're eating significantly fewer vegetables than their counterparts without ARFID. They're eating a lot less protein, and they're replacing those vegetables and protein oftentimes with grains and dairy foods. And so we help patients make some graphs to kind of show how their plate looks with typical meals that they're eating. So for example, if they're eating a lot of mac and cheese, that's a lot of grains and dairy, not very much fruit, vegetable, or protein. And then what we do is to try to help them to identify whether they have certain nutrition deficiencies. So, Cameron did mention that all of our patients are also followed by physicians or nurse practitioners who are going to attend to their physical health, whereas we work on the psychological piece. So many of them already know that they have deficiencies, or will help them to identify that they may be at risk for developing specific deficiencies. So for example, at risk for developing vitamin C deficiency because they're eating no fruits or vegetables at all. And then we talk about what might happen to them should they, persist with their diet and develop these deficiencies. And sometimes that helps to build a bit of motivation to identify specific foods to work on in the next stage. In the workbook that you'll have an ability to download, we do have a list of across the 5 basic food groups, all the different foods that the USDA has determined will fall into those categories. Certainly there are others, but it's kind of a starting point. So we call our list the building blocks, because individuals can build, complex meals or combined meals or snacks out of the specific kind of whole foods, one-off foods that are on that list. One of the things that we've also developed along with some colleagues at an app company called Novosi is an app that helps individuals actually see pictures of these foods. We kind of jokingly say it's a little bit like Tinder or Match.com for new foods, so folks can see pictures of what foods might look like and then give it a thumbs up or thumbs down as to whether they might be interested in trying these foods in stage 3 of the treatment. And so part of the purpose of stage 2 then is to develop a list of foods that folks are willing to learn about for exposure in various ways in stage 3. So it will be time to move on to stage 3 if your patient is underweight and they're steadily gaining weight. If the patient has identified foods that could be added to correct any nutritional deficiencies that either the person has or they might be at risk for. That the patient has continued to increase eating flexibility by consuming slight variations on preferred foods or eliminating minor safety behaviors. And also they've identified several foods from the primary food group building blocks to learn about in stage 3, which really is the heart of the treatment. I'm going to turn it over to Cameron to begin stage 3.
So again, in stage 3, we're going to be addressing 1, 2, or 3 of the maintaining mechanisms. The first one that I'll talk about is sensory sensitivity. We see sensory sensitivity in most of the patients who present to our clinic. And so we find that this module is often relevant. In this, they will have just finished stage 2, and so they will have selected a number of different foods that they're interested in learning about in stage 3. Throughout stage 3, when we're doing the sensory sensitivity module, we're asking the families or patients to bring in 5 foods from their list that they're interested in learning about. And they're bringing in 5 foods to each of our tasting sessions. In this, they're asked to think about foods that may help to correct nutritional deficiencies, as well as those that may begin to help reduce psychosocial impairment. So as you can imagine, for many young patients, being able to eat pizza is a food that would be socially helpful. It may also have some nutritional help, but it's certainly one of the reasons that kids would pick it would be because it would be something that would help them socially. So we ask the families to think about foods that they would like to bring in, and then they're bringing in 5 foods to each of the tasting sessions. In our tasting sessions, early on, we're doing repeated exposures to very small portions of the foods. And then in later sessions, we place heavy emphasis on incorporating larger portions of these newly tasted foods into meals and snacks that will help them to meet calorie needs as well as nutritional needs. So I'm going to walk you through what we call the 5 questions around trying new foods. So we will have patients bring in 5 foods that they want to learn about. They'll also have their workbook open at the same time. And what we're asking them to do is to walk through these 5 steps for each food that they've brought in. They can start wherever they wish, and they will walk through these steps. When I say start wherever they wish, start wherever they wish with one of the 5 foods that they brought in. So they'll go then proceeding through these sort of mindful and descriptive questions. What does it look like? What does it feel like? What does it smell like? What does it taste like? And then what's the texture like? What does it feel like in your mouth? And the idea is that we're helping them to mindfully describe these using these kinds of clear questions to give objective descriptions of the foods that they're trying. Often they have really clear predisposed ideas about these foods. It's going to be gross, or it's going to be yucky, or I don't like the way it looks. What we're encouraging them to do in using these 5 steps is to use non-judgmental words to really just clearly describe, and again, across these 5 steps. In this, you can imagine also, we're asking them to move from smelling and feeling the food to actually tasting it and then chewing it. We will ask them to take a couple bites. Usually we'll ask them to take between 2 and 5 bites of each food so that they can really talk a little bit more about it. What we find, especially in the beginning, is that it's challenging to approach these foods. Kids and families and adults themselves will bring in a wide range of these foods. As they taste them in our sessions, we're giving them an opportunity right away to give themselves credit and check off that they've tried a new food. Then we're asking them to go home and for homework to practice some of these new foods, tasting them every day. What we've set up from the beginning of treatment is that our expectation is that in CBT-AR, patients are doing something active for their treatment every single day. In the beginning, this can mean adding volume. It may also mean making small changes. But at this point, once we enter stage 3, we're asking them to begin to practice tasting some of the foods that they taste in session. What we find is that spontaneously, sometimes they do also begin to try other new foods outside of session, but the focus is on practicing and tasting foods that they've agreed that they want to continue to work on outside of session. After they've tasted the 5 foods that they've brought in, we will say to them, okay, so you did a great job. Which of these foods do you want to continue to work on this week? Okay, you want to work on 3 of them. Awesome. So what days are you going to be practicing these, and what are you expecting? When would work best for you to be practicing them? Does it make sense to do it as a tasting session, in the afternoon when you first get home from work or school, or do you want to do it with your dinner meal so that parents can be there to support you as well? What works, and really helping the family to think about it together. We find that patients become good tasters. The more that people taste things, the easier it gets both to taste those foods and to taste other foods. What we were finding early on was that people were becoming good tasters, but they weren't necessarily moving towards incorporation. We differentiate in our treatment between tasting, which is trying a small amount, and incorporating, which is having closer to portion-sized amount. We now focus pretty heavily in our treatment on also helping people move from becoming good tasters to actually becoming good incorporators. And so we offer a number of different ways and suggestions for incorporating, and we do this in our second session of stage 3 in the sensory sensitivity module, talking with them a little bit about some strategies that work for different people. For example, fading it in, maybe adding some spice, doing it a little bit differently. A lot of patients seem to like the flavor of lemon or ketchup or something as a tool, and using that can also be something that helps them early on. Potentially chaining towards a goal if that's a strategy that works for them, but it certainly doesn't need to be. Switching it up, having raw versus cooked food. Sometimes it tastes different to different patients, or they'll experience the texture differently and have comfort with one or the other. And it may be easier to start with one or the other. And then finally, deconstructing. Even if pizza is a good end goal, it might not be where they want to begin. Okay, I'm going to turn to Jenny for the fear of aversive consequences module.
Great. So as Cameron mentioned, and as I had mentioned in the beginning of the webinar today, certainly patients often present with multiple different presentations of ARFID. And so, we will like to start with the one that's causing the most distress or the most physical problems for them. So if that would be sensory sensitivity, we would start there. If it's fear of aversive consequences, we would start here with this module. So in fear of aversive consequences, any of you who are familiar with treating anxiety disorders, which I imagine is nearly all of you, this will probably look pretty familiar to you. What we do in this module is we start by providing psychoeducation about how avoiding things that we're afraid of only serves to increase our anxiety over time. It makes those things seem like more of a big deal, more untenable to accomplish. And that actually exposure, facing your fears, is going to be the best way to overcome them. And then the next thing that we do is we create an exposure hierarchy to include small steps leading up to the food or eating related situation that led to the initial avoidance. As Cameron mentioned earlier on the formulation, many times individuals with fear of aversive consequences can kind of pinpoint some kind of event or traumatic experience or a time frame in their life that kind of led up to them making these avoidances. So for example, I had a patient who got braces and then ended up having difficulty chewing and then choked on a pork chop. And then after that, she started really cutting back on her eating to the extent that she came in and was only consuming liquids. So for her hierarchy, we started with liquids being at the bottom and then moved up to increasingly textured foods in order of how anxiety provoking they were to her. And then finally at the top of the hierarchy was eating this pork chop and things that were similar to that. And so in this module, we'll start off by, creating this hierarchy in the first session of the module after providing the psychoeducation. And then in the second session, we dive right into exposures. We ask patients, similar to the sensory sensitivity module, we ask them to bring in some of the food items that are on their hierarchy. Because this one is more of a fear-based module, we'll ask them typically to bring in 2 food items as opposed to the 5, to kind of, in the sensory module, it's a bit more rapid fire. In this module, we're collecting information about subjective units of distress and looking potentially for habituation or reduction in anxiety, either within one session or over sessions. So we take our time a bit more with these exposures. And I just wanted to give you an example of a page from the workbook about how we present information about avoidance. So you can see we have a graph on the left-hand side that shows that over time on the x-axis, your anxiety on the y-axis tends to increase as you avoid feared foods. The more my patient was not eating pork chops, the scarier they became. And then on the right-hand side, we have a graph showing that the exposures and trying these novel foods, could be really difficult and very anxiety provoking in the moment, but over time, folks do tend to habituate as they find that their feared outcomes don't come true. So in addition to collecting information about anxiety levels in this module during the exposures, we also ask patients what predictions they have about what will go wrong when they try these foods. So are they worried that they'll choke? Are they worried they'll have some kind of a painful gastrointestinal episode? Are they worried that they might vomit? And then we ask them how likely it is in terms of a percentage that they think that thing will happen. And then after the exposure, we ask them that again. And typically, if they've done the exposure, the feared outcome hasn't happened, then that will go down. Certainly if the feared outcome does happen, we'll ask them if they think it's going to happen in every context and in every situation, and we might still continue with the exposures at that point. Then the last module that we wanted to share with you in stage 3 would be the lack of interest in food or eating module. And so in this case, there are really 3 interventions that we use. One of them is interceptive exposures. So if any of you are familiar with the literature and treatment on panic disorder, you know that part of the treatment for that involves exposing people to not just external stimuli like we are with the food, or you might do with someone who has a phobia of the animals. You might expose them to the animals. In this case, interceptive exposures means exposing someone to physical sensations that they're having difficulty with. And so in this case, many patients with this lack of interest have difficulty with physical sensations like feeling full, feeling bloated, or feeling nauseous. And so in the first session of this module, we do ask them to do some activities that are going to induce these sensations to show them that they will be able to tolerate them. So for example, one that we do is we ask patients to rapidly drink several small glasses of water. I had one patient who had the lack of interest in eating presentation who said to me after drinking 3 or 4 glasses of water, gosh, if this is how it feels to feel full, I think I've never felt full before. So we kind of give people an idea of what it is like to feel that way, but in a situation that's less scary than being filled up with food. Similarly, for bloating, we might ask people to push their belly out. For nausea, we might try to induce feelings of nausea by having them spin in a chair. We also do a bit of self-monitoring to increase awareness of hunger and fullness cues. So we don't ask folks to do this every single day because with so many meals and snacks, it can be fairly cumbersome, but we'll ask them in the first session to add a column to their self-monitoring record where they're already indicating what they're eating, to say where are they starting from on a 7-point scale, with 1 being extremely hungry and 7 being extremely full. Where are they starting from at the beginning of the meal, and then where can they get to by the end? And what we tend to see is that oftentimes these patients are letting themselves become either very hungry, or they experience their energy deficit actually as neutral. So maybe they say they're a 4 even though they haven't eaten for many hours. And so this can be a topic of discussion in this session. And then lastly, in session, we'll invite them to practice bringing in highly preferred foods. So, a lot of times we'll see that folks who have lack of interest also have sensory sensitivity are thinking to themselves, well, I really should try to incorporate more vegetables, or I should be eating fruit. But if they have weight to gain, it actually is helpful for them to be increasing their intake of these highly preferred foods, as Cameron was saying earlier. So we will invite them actually to bring in foods like birthday cake or chips or something like that might remind them of times that they've enjoyed around food in the past, or that would be high energy density or highly preferred, and try to have them reconnect a little bit to that hedonic aspect of eating. And so what we're showing you on the next few slides are just snippets from the workbook, which again, you can download for free, that explains to patients the strategies that we use in this module. So you see here, we talk about how to do the interceptive exposures. We talk a little bit about how to use our hunger scale and how to self-monitor around that. And then we talk to them about noticing what they like about preferred foods. And I should mention that when we do the preferred foods piece of this module, we use the exact same steps that Cameron has already shared from the sensory sensitivity piece. So our checklist to move on to stage 4 would be that the patient, if they started out as underweight, that they're no longer underweight, or they're really well on their way to being weight restored. We'd like patients to be eating at regular intervals and to really increase their volume if necessary, or if not volume, then at least their variety if they're more of a sensory sensitivity person within their meals and snacks. So in other words, they're achieving their goals of diversifying that MyPlate. We want to make sure patients are regularly incorporating foods that will help them to resolve any nutrition deficiencies or psychosocial impairment. We've had patients who, for example, have begun dating by the end of the module, or have been able to attend social events that they were previously avoiding. These are definitely things that we like to see. And also we'd like to see that their primary ARFID maintaining mechanism or mechanisms have been at least partially resolved by this point in order to move on to stage 4, which Cameron will share with you about.
And so stage 4 is brief. In stage 4, by contrast to some of the earlier stages, we will also spread out the sessions a little bit to help patients transition from treatment to out of treatment. The idea of stage 4 is really ending well. In stage 4, we're evaluating treatment progress. We do this in a couple of ways. One of them is looking back at their formulation and trying to understand where they were at the beginning of treatment compared with where they are now. Looking through their list of the building blocks foods, taking an inventory about how many foods they've tasted, and now also how many foods they've moved to incorporation. What we find is that patients are unlikely to become foodies, even if treatment is successful. So we want to be thoughtful about what our expectation is for a good outcome. Our expectation for a good outcome is for patients to no longer meet criteria for ARFID. CBT-AR is designed to expand diet, to really help folks to restore weight, and to correct nutritional deficiencies and reduce psychosocial impairment. So Jenny offered a lot of good examples about how patients can be doing really well at the end of treatment. What I would also add is that in addition to some of those, we find that families will also describe that things are easier for them, so that at this point, it's easier to go out to eat. They're not having battles about what they're eating. It's more comfortable for the child to tolerate different foods being around or even on their plate. In stage 4, we are also co-creating a relapse prevention plan. Having evaluated where the patient is and hopefully that they no longer meet criteria for ARFID, we're helping them identify what strategies have been really useful to them in treatment, which ones they want to continue, and then thinking also about where they are relative to even where they still want to be. Are there additional goals that they haven't yet met that they want to meet? And what might be some strategies that they could use to begin to continue to help themselves get there, even after they've ended treatment? So the checklist for finishing the treatment itself is that the patient no longer meets criteria for ARFID or that their symptom severity has significantly decreased. At this point, the patient is eating on their own and has incorporated several foods from the 5 food groups. The patient's growth in height or weight has increased to that expected. Nutritional deficiencies are resolved, or the patient is eating foods now in those categories that will help to resolve them over time. And at this point, the patient is no longer experiencing clinically significant or impairing psychosocial consequences. So now I'm going to turn to Jenny, who will share some of our preliminary pilot data.
Thanks, Cameron. So one thing that Cameron and I want to emphasize is that we certainly can't claim that CBT-AR is an evidence-based treatment. We haven't done a randomized controlled trial to compare it to no treatment or another type of treatment, but we did agree to give this webinar and did, do disseminate this treatment in part because there are so many clinicians who are seeing these patients and are really hungry for tools in order to help them. So we did want to share a little bit of the data that we have collected so far that's part of an overall program of research where we're collecting even more data than what we have to share with you today. But these are just the preliminary results from 20 participants who we recruited from a study of the neurobiology of ARFID and offered them to receive the CBT-AR treatment. So you can see that the average age of the patients was about 15. They were about half female, half male, and about 2/3 of them did the family version of the treatment because it was a younger sample. Of the 20 patients, 18 of them completed the treatment, and we had 2 dropouts who didn't want to continue. You can see that on average, people did tend to complete many sessions. So of the non-underweight patients, we offered them up to 20 sessions. They completed almost all of them. Interestingly, of the underweight patients, we offered them up to 30 sessions, but many of them felt, and their families felt, that they had reached their goals sooner than that. So we are considering, how many sessions are really necessary at this point. And so I want to show you a little bit more about the final findings of this study based on intent to treat analyses. So what that means is we're going to go ahead and assume that the 2 folks that dropped out had no improvements because we have no data on their end results. So what you can see is that patients and families rated CBT-AR as both credible and satisfactory. So we asked them at the beginning how credible they felt the treatment was. So in other words, how helpful did they imagine that it might be? And so on average, they scored about a 7.9 or 7.8 out of 10. After session 1, it seemed pretty credible. And then at the end, we asked them how satisfied they were with the treatment and their outcomes. So, would they recommend it to a friend, or is it something that they felt that they gotten their needs met? And you can see very high scores on that measure as well. In terms of efficacy, you can see that on average, folks decreased by at least a full point, if not more, on the party. That was that measure of ARFID severity, and the effect size was large and significant from pre to post treatment. As well, patients who were underweight did gain significant weight. This was a subset of the sample because some were normal weight or even had overweight or obesity at the start. But among those who were underweight, they were able to gain significant weight with a large effect size. It was about 10 pounds. And then finally, in terms of efficacy, we did see that food fussiness decreased, as did food neophobia. So in other words, folks felt more comfortable with trying new foods at the end of the treatment and less uncomfortable with trying new foods. And you can see that those were large effect sizes as well. So we were very pleased with the findings of our pilot study. But again, we need to move forward with a more rigorous testing of the approach before we could claim that it's evidence-based. Oh, and lastly, I should just mention that the number of new foods incorporated by our patients in the study was about 18. So that means, folks who were not eating these 18 foods in the beginning, they then incorporated them so that not only were they tasting them, but actually eating full portions of them in their regular meals and snacks by the end. In terms of our acknowledgements, we just wanted to thank all of our collaborators. Even though Cameron and I developed the treatment, we have so many wonderful collaborators here at Mass General in the greater Boston area and really throughout the United States. We want to thank our funding agencies for the CBT-AR trial, as well as our observational and neurobiological studies. And then lastly, we wanted to just provide you with some free resources before we do the Q&A. So you can feel free to reach reach out to me and Cameron by email with questions about the treatment or just to, share your experiences with using it. We've mentioned a few times throughout the webinar that there is a workbook for patients and family that you can download for free, and we've put a link to that. We also mentioned that the party interview is downloadable for free as well, and put a link to that as well. You can use the party to characterize and diagnose ARFID, to evaluate treatment outcomes, and so on. And then lastly, the app that we mentioned that we use in stage 2, called Fudo, is also available for free. One thing to note about the app is that it doesn't deliver the entire treatment through an app. It's only just that one portion about the building blocks with the food. And without further ado, we'd love to turn it over to our moderator, Marcia, and we'd love to answer any questions that you guys have.
All right. Marcia, it may be that you're speaking, but we can't hear you yet.
Okay.
Oh, there you are.
How's that? Okay, thank you. So we're starting our question and answer period now. We do have a number of questions. Any of you that haven't asked a question would like to send away in the chat, the question and answer box at the middle of your screen at the bottom. So here's the first question. Is there a difference in treatment for individuals who might have autism or be on the spectrum?
That's a great question. So we had mentioned that folks need to be at least 10 years old and kind of developmentally appropriate.
And I'm having a hard time hearing you.
Oh, sorry. I'll go ahead and speak up. So we have included some patients with autism in the treatment. They have to have fairly high functioning autism to be able to take part. So for folks who aren't able to kind of engage in some abstract thinking and challenge their thoughts through the exposures, they might benefit from more of like an ABA approach.
Okay, thank you. Here's a question about using rewards for tasting and trying and eating more foods. What's your thought about that? One of the participants has worked with parents who are using rewards and wondering what's your thought and advice on that?
Sure, we actually do use the rewards when they're helpful. So we often don't introduce it from the beginning, but we do find that often parents do. So what we'll do is, we'll kind of work with what's going to work for the families. So by contrast, again, one of the things Jenny and I think a lot about are the differences between these patients and those with the more typical eating disorders. Again, by contrast to the patients with, let's say, anorexia nervosa, where they're much, much, much more likely to prefer a delayed reward, these patients typically want a reward right away. And we find that they're very responsive to incentives. And so again, in the spirit of trying to do what works, we do work with the families around thinking about an incentive schedule that makes sense. So often we find that, earning points, for example, or doing something in kind of a gamified way can be helpful for kids around promoting engagement, and really trying to then work with the families around making the rewards realistic and something that they can actually deliver on for behavior can be really helpful. And so we certainly use that as it's useful.
What about spitting? Do you allow kids to spit out food as they're trying it in exposures? How do you handle when a child spits out food that they don't like?
That's a great question. So we don't introduce the idea. We don't have like a spit bucket and say, all right, if it's really difficult, you can spit it out. But if it happens spontaneously, we might just really praise the fact that they tried it and say, oh, that must have been really, a tricky one for you or really difficult, great job trying it. Do you think that next time we could move you towards moving it to the back of your mouth and swallowing it? So we would normalize it, but try to move them past that if possible. Now, that being said, Cameron mentioned that folks bring in 5 new foods. It may be that in a session they pick 3 that they want to continue working on because they decide that 2 of them they just really couldn't tolerate, and that's okay.
And they may elect to come back to it, or they may not.
Yeah.
How do you handle when the patient is eating very, very slowly? This is a question from me where families say, well, she's taking 3 hours to do dinner.
Yeah. So, I mean, again, I think it's trying to figure out what's going to work for the family. So always first, what I would try and do is name that as a behavior that we're working on. So is it something that they're doing because, for example, is it that they're feeling full, or is it related to the taste? Whatever it is, trying to understand that, and then giving them an opportunity in session to be challenging it by practicing something different. So honestly, sometimes such simple things as saying to the kid, one strategy we use is hold your fork and don't put your fork down in between bites. Sometimes the kid is just like so excited to talk about different things that they're finding themselves chatting during the whole meeting or during the whole meal rather than eating while the other family members have, finished their meal. So sometimes it's just being really concrete and behavioral around different ways that they can interrupt the behavior that they're seeing. But then we will sometimes also help with rewards around that. So, if we're able to help you do this meal a little bit more quickly, or do 5 bites before you then ask a question, that, then you can go ahead and ask your question, because we're dying to hear what you have to say, but we also know you really need to get those bites in more quickly. So it's just trying to be creative around that.
How do you deal with kids with ARFID who, to use a term, are overweight? Do you do anything different?
No.
No.
Yeah, in short.
Yeah, we've seen many folks who have the sensory sensitivity presentation who, are living in larger bodies and have higher weights, and we really don't touch that, so there's not a lot of evidence that weight loss treatments are effective, and we don't want to be causing any further problems that might be iatrogenic. So although we do take people's weight because we want to make sure that they're not, say, like losing weight by shifting all their eating to vegetables, or maybe gaining weight by increasing the volume of preferred foods too much in a way that might be unhealthy for them, we really do the same treatment for those folks, and we never ask people to try to lose weight.
So here are a couple of questions about how to handle if X happens in a situation. If the child is too anxious to try a food in a session. The other question is about what if the patient or the family doesn't bring any food in as instructed?
Yeah. Well, maybe we'll start with the second one because it's
Sure.
a little easier. I know when I went to high school, if you didn't bring your gym clothes, they'd have like these loaner clothes that you had to wear. So we kind of do the same thing in the clinic. We have some non-perishable single packaged items that we can give people. So they, just like it was undesirable to wear the loaner clothes, it's a little undesirable to try surprise foods that Cameron and I or our colleagues have selected, like dried fruit or nuts for folks who aren't allergic. So basically we have substitute foods, and we're lucky that our clinic is nearby to a few different convenience or grocery stores, so we'll send people out to pick them. So we would never say, oh, too bad you didn't bring the food, you don't have to do it. And I'll let Cameron deal with the anxiety question.
Yeah, and I would just say, kind of related, I think, to both of the questions is the idea that we want the patient to have bought into what we're doing. So at the end of whatever the previous session was, they are already saying to you, okay, yep, these are the 5 foods we're going to work on next week. So there's a verbal commitment. There's a plan for what they're going to be doing. They know this is actually part of their homework, is to get these 5 foods and bring them into our session. If it's going to be challenging even for them to bring the food in, then we need to brainstorm how are they going to be able to do it. And if they're not going to be able to do it, but they want to try X, Y, or Z food, then maybe the first 5 minutes of our session is heading to the grocery store and picking that food up together. So we want to both, have them plan for it and have them have already bought into, okay, yeah, this is a food I'm willing to work on. That being said, they might still come in and be pretty anxious about trying that food. We just try to roll with the anxiety. So if they're not willing to actually take step 4 of tasting it, and then step 5 of chewing it or telling you about the texture in their mouth, hopefully they can at least do 1, 2, and 3. So that they're describing the look of it, they're feeling the feel of it in their hands, and then they're smelling it, so that they are doing something to approach it. And typically with a food like that they're only able to go through the first 3 steps for, that's going to be something we're going to ask them to bring back in again next time.
Similarly, if the anxiety is occurring in the context of a fear of aversive consequences module, we'll add that to the hierarchy. So we've had patients who are so afraid of certain foods that the first thing they're doing is maybe just looking at pictures of those foods on the hierarchy. Or, we've had patients who have had the food item all the way across the room from them and just being in the same room as it, or you had a patient even just talking about the food was challenging. So we'll add those to the hierarchy so patients can get success on kind of easier versions of it before they're actually tasting it, if we're doing the anxiety module, and that's really the maintaining mechanism.
So I think we have time for one more question. This one is also about hierarchy. Any additional tips on how to create a hierarchy when there's a phobia of vomiting, particularly when it's a fear that volume will induce vomiting?
Sure. I think we would kind of do it as we would any type of hierarchy. So we would talk, the hierarchy again could start with something as simple, in quotes, as simple as using the word vomit, talking about the word vomit, perhaps even writing it before being able to say it and talk about it. But moving through a hierarchy that usually goes from something like talking about the word to looking at maybe cartoons of, to then looking at pictures of, to then looking at videos, again, perhaps cartoons first of, and then real life videos of, and then perhaps acting it out in session. Doing the hierarchy can actually be a lot of fun. For some people, sometimes more for the therapist than for the patient, but doing some kind of, sort of play with it as well, like acting about it. And then actually moving towards having them feel many of those interoceptive cues. So is it that they feel nauseous? Is it that they feel full? Is it that they feel pain? What are the different kind of physical cues that they get? It may be that during the course of your 20-ish sessions, they will have an experience of vomiting or being around a friend who has vomited. Those are all things that will come up in their hierarchy. Are there behaviors that they're avoiding? Are they avoiding eating before being in the car, for example? Are they avoiding eating before going to gym class? Things like that, all of which can be targeted in their hierarchy to get them more comfortable with it. Ideally, you'll then also present them with potentially pretend vomit, fake vomit, that there are many recipes for online that you can also help them to get more comfortable with it. And there are a lot of different levels of being comfortable. So those are some ideas. There actually is also a wonderful website that I probably can't advertise, but if you look up different options, there are some resources for targeting emetophobia that also help around coming up with hierarchies for that.
Well, what a way to end. Fake vomit, etc. Well, thanks everyone. Thank you to Dr. Thomas and Dr. Eddy. This was most interesting. And just a reminder that you can find out more about this and other upcoming webinars by visiting aedweb.org and clicking on the events tab. Thanks everyone. Bye-bye.
Thank you.
Bye.